everyone. My name is Jorge Castilla from WHO. I have the pleasure and honor to be the incident manager of WHO support to the response between the months of October and November. And it's great to have this opportunity from a point of view of public health. What I saw in Chad with the Sudanese refugees and the Chadian population, I would define it as the 3M, because malaria would represent the charge of diseases. Malnutrition is not only the situation of the arrival of the refugees from Chad, but also the very restrained funding that makes it difficult to maintain even the supplies of food. But the third M is mental health and psychosocial support, because among the people that I interviewed, more than half of them have stories of having lived and having suffer or witness the consequence of an extreme violence. There are more than 250,000 of this population that is in need of mental health and psychosocial support, not to mention the Chadian population. So let me go directly to the first participant. We will start by Dr. Eric Endry, who is the coordinator of the health cluster in Chad, followed by Madame Hélène Solange Camang, who is the coordinator of the protection cluster. Over to you, Eric.
Hello, ladies and gentlemen. Thank you. I'm not sure whether you're hearing me well. Can you please confirm? So first, I would like to extend my gratitude. Thank you for the interest that you have expressed by registering on the webinar. So as I have been introduced, my name is Eric Didier. I'm the Health Cluster Coordinator in Chad, and I have my colleagues next to me. They will also introduce themselves. We must also have the Secretary General of the Ministry of Health and Prevention, but at the moment he's in another meeting, so we will hope to have him later on in order to launch this webinar. But now, without further ado, I will give the floor to Mrs. Hélène Solange, the Protection Cluster Coordinator in Chad. I give you the floor. Thank you so much, Eric, and hello to each and every one of you. My name is Hélène Solange Kamgag, the Protection Cluster Coordinator in Chad. It is a real pleasure to speak today, and more particularly to have this activity in Chad. Thank you so much. There's also Dr. Rauda, the Director of the National Mental Health Program. I give you the floor. Hello, thank you, and hi to everyone. It is a great honor to be among you today, and I think that Dr. Didier has introduced me well. My name is Dr. Rauda. I'm the Director of the National Mental Health Program in Chad. Thank you. Thank you, Eric. Should I give you the floor or give Dr. Fahmy the floor? So I think that it is time to give the floor to the health cluster, to the protection cluster coordinator in Chad. I give you the floor, Mrs. Hélène. Thank you so much. Mrs. Madam Coordinator of the National Mental Health Program, Mr. Moderator and WHO Senior Emergency Coordinator for Health Emergency Response, ladies and gentlemen, representatives of IOM, UNHCR, and IRC, partners of this event, representatives of donors and funders. Dr. Fahmi Hanna, representing the IASC at the global level, and Mr. Dr. Eric Didier, the Health Cluster Coordinator. Dear ladies and gentlemen, and dear colleagues and dear members of the Health and Protection Clusters, it is a real pleasure to speak today on behalf of the Protection and Health Cluster as part of the webinar on mental health and psychosocial support, MHPSS. We are delighted with your massive participation in this event, which is proof of the interest aroused by the subject. Ladies and gentlemen, the threats and risk in protection and health faced by populations affected by the various crises that Chad is going through sufficiently demonstrate the needs to strengthen the resilience of affected populations by improving access to basic social services, with particular emphasis on mental health and psychosocial support services. Today's initiative is a significant contribution to protection and health through the promotion of psychosocial well-being and the prevention and treatment of mental health problems of people affected by humanitarian crises. First and foremost, women, children, and people with specific needs or special needs. It also aims to mobilize stakeholders around a common ideal on the one hand, and on the other hand, to pool resources in a context of underfunding of the Chadian humanitarian response plan for several years. It stands as an opportunity to support the state in establishing a mental health and psychosocial support service offering capabilities and meeting basic needs while taking into account the challenges of recurring and multidimensional crisis. On the short run, it will contribute to reducing the gap regarding Objective 3 of the 17 objectives for sustainable development by 2030. Ladies and gentlemen, we would like to take advantage of this webinar offered for the occasion to thank the Chadian authorities who played an important role. Thank you, Mrs. Coordinator of the Mental Health Program. Thank you for playing an important role in the completion in January 2024 of the assessment of mental health and psychosocial support needs conducted by the WHO in close collaboration with the Chad Health Cluster, and also with the support of the Inter-Organization Standing Committee, to whom we also extend our thanks. The alarming results of this evaluation, on the one hand, presented by the state of play on mental health and psychosocial support, the weakness of current initiatives justified by low funding, gaps, and also needs, and on the other hand, the recommendations around 12 points to which the presentation which follows will return, and whose implementation requires adequate financing, all that in order to achieve the objectives of popularizing this theme, strengthening the capacities of stakeholders, and providing assistance to cases that already show signs of illness. Madam Coordinator of the National Mental Health Program, ladies and gentlemen, to conclude, I would like, on behalf of the Health and Protection Clusters in Chad, to once again extend my sincere thanks and my gratitude to the State of Chad through the Ministry of Public Health and Prevention for this laudable initiative of resource mobilization and for this remarkable cooperation, which is reflected in its constant and multifaceted support, aiming at the facilitation of humanitarian access and the response to the ever-increasing problems of populations affected by various humanitarian crises. Thank you so much. Thank you for these introductory remarks. I forgot to tell you that to enable interpretation, you can click on the globe icon at the bottom of the screen and choose the language that you wish to hear. And to only listen to the spoken or to the main audio, you can actually choose to listen in main audio only. And now, we have the pleasure to introduce Dr. Fahmi Hanna, who is the WHO HQ Technical Officer and also IASC Reference Group Co-Chair. And then we will give the floor to Dr. Ernest Anda, who was deployed on behalf of the interagency of MHPSS search. Dr. Fahmi, welcome.
Shukran, Jorge. Thank you so much. Colleagues, we always talk about the good practice of doing cross-cutting mental health and psychosocial support across sectors and clusters. And today, the good practice comes from Chad by this webinar co-organized by the health cluster and the protection cluster, showing the importance of this area of work as cross-cutting, showing also the need and prioritization of local authorities who are with us on this webinar. So I thank all colleagues who were involved in making mental health and psychosocial support in Chad is a priority. Next, please. Colleagues, according to the minimum standards of mental health and psychosocial support, we need one cross-cutting mental health and psychosocial coordination group. In my presentation and sharing the findings of the report, and I kindly ask my colleagues in sharing the report here in the if we can share, please, the PDF file link in the chat for the report in French and English. I'll go one by one on the minimum standards. First, having one cross-cutting MHPSS group. In fact, this picture is from the group in a meeting organized by ADRI, co-chaired by our colleague, the co-chair of the group, Ernest, together with the representative of the Ministry of Health. While the sub-national group has been activated by an interagency MHPSS surge deployment, the national group, during the time of the meeting, was remained inactive. The sub-national group in ADRI had more than 15 members representing various international NGOs. Next, please. This is a reminder to us that MHPSS is not about health sector, not about protection sector, not about education sector. It's a cross-cutting area of work with services well integrated in various sectors. And this is from the minimum service package and the IC guidance. Next, minimum standard, please. Build your interventions based on assessment of available needs and resources. Before this mission, I'm sure like many of you, and this webinar has gained significant interest with many registration, more than 250 people registered for this webinar. I think because there is very little known and very little available literature and assessment coming from Chad. And that's one of the key gaps we identified. My first language is Arabic, which is the language spoken by the refugees in the East. I conducted in collaboration with UNHCR and with colleagues from UNICEF and Chadian Red Cross focused group among refugees who came mainly from Darfur. One of the key things I have identified during the focus group, many of which are included in the report, is that you see its link here in the chat function if you'd like to read more. But one of the key findings is that the MHPSS complaints of the displaced people from Darfur, displaced in east of Chad, many of these complaints are lost in translation. While many of the organizations have recruited interpreters who speak Arabic, some has not, and some has French-speaking mental health providers. When a person from Darfur expresses the mental health need, they tend to have psychosomatic complaints referring to body function rather than to emotion. For example, instead of saying I'm anxious or I'm depressed, saying I have a headache. Colleagues, participants in these focus groups from Chad were telling me that they end up, when they go to the clinic, having a paracetamol and analgesic instead of an intervention to deal with their emotional problems because their complaints were lost sometimes in translation. Tools like the one you see here in the picture are tools that can tell us how to do cultural primers to adapt MHPSS intervention for people like the people from Darfur in east of Chad. Next, please. Engage community, including the most vulnerable. And that's one of the areas where there is very limited action done at camp settings I have seen. There are some initiatives like this board I have seen in one of the, in the mental health facility in Anjamina, which explain try to normalize the process of seeking help from mental health professional, but engaging communities in mental health and psychosocial support. One of the findings from the mission, it was extremely limited. Next, please. Minimum standards tell us that everyone need to receive capacity building on basic psychosocial skills such as psychological first aid. The good news is that resources are available, such as the one here. And in fact, it's not only available in local languages in French or Arabic, but it's actually available in Chadian dialects, including Shua Arabic, like the basic psychosocial skills guide here. One of the things we need to do currently is not happening is integration of basic psychosocial skills as a cross-cutting topic for all frontline responders in various emergencies in Chad. Next, please. Chad has no specialized mental health professional. The only psychiatrist in Chad was in 2019. Now, the only mental health specialized facility is actually in the central hospital, run by a paramedic, by a couple of nurses, couple of psychologists, only 4 beds. The only way to solve this problem in the intermediate phase is to do task sharing by developing and scaling up adapted interventions such as the MHPSS Humanitarian Intervention Guide developed by UNHCR and the World Health Organization. While there were initiatives from multiple organizations approximately 5 years ago to adapt and implement MHPSS Humanitarian Intervention Guide, during my visit, I have not seen this being implemented. There are also severe shortage of psychotropic medication. This is the image from the warehouse of medications that I have visited in Apichi, which is a central warehouse for east of Chad, where psychotropic medication were not available because there are no prescribers. The only prescriber is in this clinic, in this image that we see actually from the IRC, International Rescue Committee. We have the only psychiatrist who is an international practicing in east of Czech. A promising intervention, but that means in a country double the size of France, the only specialized mental health professional we have at the border providing services for refugees, and that was the situation since 2019. Next, please. WHO have set of scalable psychological intervention. We recommend they are implemented in humanitarian emergencies. This yet to happen in Chad. However, there are promising initiatives by MSF Spain and MSF Switzerland by having psychologists deployed in the east. This is an image from camp around Adri area, where together with my colleagues from MSF, from WHO and UNHCR, we visited the psychological intervention clinic. While these are provided by specialized psychologists, but there are no attempts currently to scale up scalable psychological intervention based on the findings from the mission. Next, please. Another minimum standard that the sphere reminds us, and also the ISC guidance, is giving attention to institutes, including psychiatric hospitals in emergencies. The picture you see here on the right side of the screen is actually from the central hospital, the only inpatient unit, 4 beds for the whole country. There are 3.7 million Chadians and 250,000 of Sudanese with severe mental disorders, mild, moderate to severe mental disorders. However, for inpatient facilities available only 4 beds. And one of the sad situations is that this is actually part of the dermatology and infectious disease department. That can show that the area of work is to some extent stigmatized, and there is a need to shift to community-based services and into task sharing. This is during an assessment for the central hospital mental health unit, while the team there is doing all their effort to scale up the service, but the team in number and the capacity building opportunities they get is extremely limited. Next, please. Another blind spot I noticed, despite coming up several times during the focus group discussion, was substance use. Alcohol, tramadol, and cannabis were frequently reported being used in the camp and previously before displacement as coping mechanism. However, this is very limited intervention by health and protection various partners. Next, please. Colleagues, needs in mental health of mental health and psychosocial support in Chad are huge. More than 98% of people who need the service are not receiving it. More than 3.7 million people with mild, moderate to severe mental health condition among the Chadian population, more than 250,000 among the Sudanese. Paradoxically, Chad is one of the most affected countries, usually referred to as the most affected country by climate change. Chad is also having one of the countries with the biggest refugee population in Africa. Chad is not only one of the world's largest emergency responses, but it's also one of the least funded. And that affects mental health services significantly in a country with no specialized mental health professional since 2019. However, previous experience tell us that opportunities can come with emergencies and attention, including a webinar where international partners and various actors come together to discuss from the government, from the clusters, what to do to mental health and psychosocial support to scale up the service in Chad remain an opportunity. Next, please. We know what needs to be done. We have from the ISC the minimum service package, which is an evidence-based prioritized set of actions across clusters for situations like this. Next, please. In the report, which you can find here in the chat, there are 10 recommendations which I saw based on discussion with various stakeholders in Chad are priorities for the coming 1 to 1.5 years. They include, among others, activation of the National MHPSS Technical Working Group, developing a cultural primer to orient health and other service workers in the camp, implementing MHGAP. While we don't have a psychiatrist, but we have neurologists in Chad that I think can be trained for task sharing. We need to train at least 2 from every district. To engage the Ministry of Higher Education, unless we review the curricula of various health professionals, the situation will remain the same for years. We can engage the African CDC, and we started to have discussions around this. To procure mental health medication as part of the IHK, to use the existing basic psychosocial skills guide, to conduct a national gap analysis, not to forget the psychiatric hospital and the healthcare staff that are working there. Colleagues, I'll stop here and hand over to my colleague Ernest, who I was really inspired by his work during the mission and how he was able to activate the subnational working group in the East. And I take this opportunity to thank our colleagues from USAID, DHA for supporting my mission and make it possible to have one of the first global missions conducted in Chad focusing on mental health. Over to you, Ernest.
Thank you so much, Dr. Fahmy. Hello, everyone. My name is Ernest. I am a therapist and also interagency MHPSS search deployee since 2004. And I would like to present this afternoon some information on our deployment, more particularly in Eastern Chad. And it goes without saying that the crisis that has started in Sudan since April 2023 has had serious consequences on the local population, but it has also affected other populations, such as in Chad and all those from Chad living in Sudan. So this presentation will encompass the following point: the context of the deployment, as well as its objectives, the main achievements, and some challenges and lessons learned. But of course, some of the recommendations will not be repeated as they have been mentioned by Dr. Fahmy, my colleague. Great. So as I was saying, the armed crisis in Sudan took place between the paramilitary group, the RSF, the Rapid Support Forces, and the Sudanese Armed Forces. So the RSF is a paramilitary group, and it has been very atrocious that it has caused a massive displacement of Sudanese populations to neighboring countries, more particularly in Chad. And at the end of January 2024, we registered around 523,431 victims of serious exactions, sexual violence, injuries, loss of property, and they were hosted in 3 provinces of eastern Chad. So in the national departments, the Chadian Authority, even in UNHCR and IOM. We move on to the next slide. So these are some images that show the flux of the population. And this also illustrates some of the zones. Please slowly go back to the previous slide. Yes, thank you. So the hosted populations by the Red Cross, by the ICR, and even at the borders. So you can see them in these photos. And the government of Chad has witnessed the atrocities experienced and thought of the interest of the population. So along with the MHPSS National Working Group, proposed to strengthen the response by drafting a strategy on MHPSS to respond to the humanitarian crisis in eastern Chad, and they did not hesitate to include mental health and psychosocial support. And we have mostly worked with the technical group and the MHPSS National Working Group. So there was a rapid deployment of the MHPSS specialists in Chad through the Dutch search support and the IASC reference group and UNHCR, and they actually facilitated this smooth intervention, and we were supported by the IASC in Chad along with other associations and in different locations. Next slide.
The objective of the deployment were to strengthen the technical coordination around the MHPSS, provide technical support also to reinforce the capability in the MHPSS domain and organize training, provide technical supervision for the intervention. Next slide, please. When we talk about the achievements, the main achievements that we did so far in Chad, so we evaluate the needs and we did the evaluation and we want to see what the local population is in need of and the refugees as well as the host communities. So this allows us to know what are the package services that they need, and we assessed also the mental health needs and we identified them, and the report was drafted and now we are finalizing the report and we are going to share the final version once it's done with all of you. But what was interesting in this evaluation is that we added another evaluation about the lacking services, and this is a tool developed by us to predict what are the needs in the MHPSS sectors and what are the implemented actions to find solution for that. And so we had a mapped all the activities that are done in the zone for the refugees, for the host communities, and for everyone else. Next slide, please. Next slide, please. At the end of this evaluation, we realized some things and we had main achievement. We wanted that we need to have a coordination under the leadership of the head of the district. We also started the work on the MHPSS for the communities in order to coordinate all the initiatives related to the mental health. And we had the main stakeholders who were working in this zone. And also they were tackling the protection services. And I think that they are still acting so far. And you can see the main stakeholders and in the pictures on the right side of the slide, and they were working in the hospital of the district and the reunion and the meeting hall. And more than the coordination, also we worked on capacity building of the 296 NGO workers who participated in the trainings of capacity building. And we had also MHPS intervention for all the people who were impacted on a longer term and during these crises. So the stakeholders in the health sectors, we had more than we offered them psychological first aid for more than 273,511 individuals received medical consultation, and several people received rehabilitation, mental health rehabilitation. And also we provided services for 150 women and adolescent girls and boys to allow them to benefit from this initiative. This project was very fruitful, and also the communities and population benefited from these initiatives. Next slide, please. Regarding the challenges, we faced several main challenges, and we saw that there is a huge need to implement the standards. One person over five needs support for the SMS PS, for the MHPSS, and also the population and the refugees in that zone need this help and they need support, and they have more needs than the local population, and also the services are limited. We only had one partner and one psychiatrist in Chad who is specialized, and thank God we are trying to democratize his knowledge and his services. However, we cannot but notice that there's lack of professionals. Also, there is a need to reinforce the capabilities of the stakeholders and also the cadre of people who are not professionals and who can support. We also notice that there is a lot of alcohol consumption and tobacco consumption, and also there are not a lot of stakeholders tackling these issues in that zone. Next slide, please. And finally, we need a strategic cadre and framework on the national level that can guide the stakeholders in order to do their intervention in relation to the MHPSS. And we have seen that there is a huge need, and this is needed by the medical health and the mental health services providers and the professional actors and stakeholders who are working in Chad to be included in the national strategy. Next slide. I think that we arrived at the end. Thank you. Thank you so much. Thank you.
Thank you so much, Jorge and Ernest, for the excellent presentation. Just to highlight that this series of missions, the interagency one through Surge and the IC-MHPSS reference group co-chair one, is going to be followed next month, actually, by a mission by the lead on MHPSS at the UN Refugee Agency, Dr. Peter Van Vogel, who's going to visit Chad and east of Chad to provide support. And we will continue our follow
I will continue with another intervention from the governmental sector. The Secretary General was not able to participate, and this is unfortunate because they know how to give us the information. However, we know that we have with us the director of the National Program of Mental Health, Dr. Rauda Muhammad Yusuf. It's very important because our colleague talked about the needs in regards of the populations and refugees. However, in order to describe the local resources, we know that there's a large number of children, people who don't have access to the resources. So I would like to give the floor to Dr. Rauda Muhammad Yusuf. Welcome. I will talk and I will start with the presentation of the program. And can you move to the next slide? Thank you. Here we are talking about the identification of the program. So I just wanted to say that the program was born in 1998 with a ministerial decree in Jamena, and we have a huge hole and in the Zandami and also in the Ministry of Public Health, and our intervention domain should be on the national level, and the intervention zones and our domain is to design and organize psychosocial and psychiatric assistance, elaborate the national politic in regards to the mental health, and also provide the medicines and also raise awareness on the mental health. As for the budget, we did not have any support from the state or from any partner. Next slide, please. Here, I wanted to show you the staff who are taking care of the mental health people who suffer from mental health problem. We have two province, the Shure and Dr. Fahmi visited. We have 5 people who are taking care of those people. We have 2 technicians specialized in mental health, one attached person from the Ministry of Health, one psychologist, and one social services provider. And also we identified in the public hospital of Mongo in Gera, where we have an evangelical mission who understood the interest of having mental health services. So they trained a nurse from the government to social helper, social assistant, and they take care of these people since 2002. Next slide, please. We took into consideration some main indicators. As we said, we were not able to identify more than these indicators, one of the provincial hospital and the other one of the Jiran. We were able to identify some illnesses, and the total of case, cases for the psychosis and paranoia and other mental health problems. We were able to identify the number of patients and people who are suffering from these diseases in this table. Next slide, please. The total, as we said, from January to December 2003, in these 2 hospitals, they were able to take care of 1,706 patients, and we saw that schizophrenia mostly, the patients were suffering from schizophrenia mostly. Next slide, please. As my previous colleague have shown you, these are the conditions on how to where the people are taking care of the patients. We have one hall, one room, and another room where we do the consultation. And on the right side, you can see the hospital CHOU. Generally, they have two rooms, two beds or four beds in each room. However, the hospitalization cases are rare, and down there the picture shows the consultation office of the two high and senior technicians who take care of the patients. Next slide, please. The main problems and challenges that we faced, and we proposed some measures to take care of them. We don't have a location to take care of these patients. And also, I think that my previous intervention said that we need to collaborate and coordinate with the partners who are acting in this domain. We know that there is a technical group who is providing the support, social support, since a long time. However, we need to reactivate this relation, and this group should be reactivated so we can coordinate in a better way with our partners. And we don't have a legislation regarding the mental health. Next slide, please. In addition to that, here also for the population, as we can see, they don't know about the mental health as is, and what are the illnesses, mental illnesses. So there's a need, and if a person shows a psychosocial problem or social illness, the population will go and see the local practitioners. They say that they are more accessible. Therefore, we need to communicate inside the communities and raise awareness. And also, we have a lack of the public structures of rehabilitation and hosting structures. Therefore, we need to activate and reinforce the capabilities. Next slide, please. We don't have a protocol on how to take care of the mental illnesses or a register to do the consultation, psychiatric consultation. So we took these data, and it was very hard to collect data because we don't have a register that's connected, and also we don't have the data related to the mental health on the national level. So we don't have these data. So we want to do the evaluation of the status on the national level in context with the mental health. Also, it's very hard to have the medicines and the generic medicines. Sometimes they are not provided in the pharmacies in the provinces or also in the national centers. Therefore, the accessibility for these medicines need to be more accessible for the ill people and sick people. And also, we need to dedicate a budget for this program because we don't have a program for the mental health and we don't have a budget for that. And this is a problem because if we want to do some activities, we will be limited by the minimum budget that we have or the lack of budget that we have. Next slide, please. We do have some perspective and to have an evaluation of the situation on how to take care of the ill people and people suffering from mental health problem. Also to have a protocol on how to take care of the illnesses, mental illnesses. So we know about the illnesses and how to take care of them on the national level, and also to have a database on the mental health. So far, we don't have a database on the mental health, and also we need to talk with the nurses and the specialists and the emergencies of how to take care of these patients. And it will be ideal if we can implement these activities on the national level, and also to have the accessibilities for the medicines, and also to have a national politics for the mental health in order to elaborate and reinforce the mental health on the national level. Next slide, please. Of course, this is the strategic plan. We need to do a strategic plan. We don't have a national strategic plan for the mental health, and also this is an emergency that we need to do because this will alleviate the burden on us and the work that we have, and also for the National Day of the Mental Health, we want to have this strategic plan by October, and also we want to raise awareness more and more within the population, so the population would know what we call mental health. Next slide, and I think I finished. Next slide. I just wanted to thank you. This is a family photo that we took during the International Day for the Mental Health in 2023. As you can see, there are a lot of directors from the centers, so I would like to thank you so much. Thank you for your participation, and also I would like to highlight what you said. The need of coordination, and also when we want to help the Sudanese refugees, also this is the opportunity to reactivate this mental health program that is very helpful for the country. So I would like to give the floor to Anne-Marie Mackenzie. Because,
Following the developments at the level of the health sector and the protection cluster. So over to you, Anne-Marie.
Hi, everyone. Thank you very much for inviting me to this important conversation.
Thank you very
and
much
thank you as
for
well to the
inviting me
previous
to this
presenters
important
who not only
conversation.
outlined
And
some
thank
of
you
the
as well to the
pressing
previous
needs for
presenters
increased
who not only
MHPSS
outlined
support
some
in
of the
Chad,
pressing needs
but
for
also
increased
presented the
MHPSS
recommendations
support
and
in
way
Chad,
forward to
but
address these
also
critical
presented
needs.
the recommendations
So I'm
and way
Anne-Marie
forward to
Mackenzie. I'm a
address these critical
humanitarian
needs.
protection
And so I'm Anne-Marie
advisor
Mackenzie.
for
I'm a
USAID's
humanitarian
Bureau for Humanitarian Assistance, and I cover BHA-funded protection and PSS programming in Chad. So thank you for having me. The Bureau for Humanitarian Assistance is committed to right-sizing protection and PSS activities within our portfolio, both at the global level and at country levels. Both at the global level and at country level. Our funding
BHA consistently increases our funding
and ensures that there's
protection
appropriate
PSS
staffing,
activities,
capacity,
and
and
ensures that there's
resources
appropriate
for partners to
staffing,
carry out
capacity, and
evidence-based
resources
for partners to carry out
to communities
evidence-based
most in need.
PSS interventions
Although
to
funding
communities
streams
most
right
in
now are
need.
increasingly facing
Although
constraints,
funding streams right now are
BHA
increasingly
continues to
facing
prioritize
constraints,
support
BHA
to
continues
protection
to
and
prioritize
PSS
support
activities.
to protection
BHA
and
increased
PSS
the amount of
activities.
funding specifically
BHA
dedicated to
increased
protection
the
and
amount of
PSS
funding
activities
specifically
by
dedicated
$100
to
million
protection and
in the
PSS
past
activities
fiscal year,
by $100
even though
million
the overall
in the
budget for
past fiscal
BHA
year.
did decrease.
Even though the overall
In
budget
fact,
for
the percentage
BHA
of
did
protection
decrease.
sector and PSS
In fact, the
activities
percentage of
BHA
protection
funded
sector
that
and
year
PSS
tripled.
activities BHA
Key to
funded
this
that
increase
year
and
tripled.
supporting PSS
Key to this
protection
increase
interventions
and supporting
is implementers
PSS
and humanitarian
protection
actors
interventions
proposing
implementers
PSS
and humanitarian
protection
actors
programming,
proposing
and as well demonstrating their
PSS and
effectiveness
protection
of their work,
programming, and as well
and
demonstrating their
commitment to
effectiveness of their work,
evidence-based PSS
and
protection
their
programming.
commitment to evidence-based
In alignment
PSS
with our
protection
commitment
programming. To right-size
In
protection
alignment with our
programming
commitment
and
to
fund critical
right-size
protection
protection
work,
programming,
BHA provides
and
consistent
fund critical
support to the
protection work.
reference groups
BHA
that
provides
Dr. Fahmi
consistent
Hanna
support to the
co-chairs.
reference groups that
BHA's
Dr. Fahmi
contribution
Hanna
aims to
co-chairs.
increase the quality of
BHA's
support to the field
contribution
in
aims to
protracted
increase the quality
emergencies
of
or rapid
support to the
onset
field in
disasters,
protracted
as well as
emergencies
for
or rapid
intercluster
onset
coordination
disasters,
on
as well as
MHPSS.
for intercluster
BHA
coordination
has
on
funded country-level
MHPSS.
support missions, and
BHA
Dr.
has
Fahmi's
funded
visit
country-level
to Chad
support
as well,
missions,
and we
Dr.
support
Fahmi's
in-person
visit to
and
Chad
virtual
as well,
capacity
and
building
we
for the
support in-person and
MHPSS
virtual
surge
capacity
mechanism.
building for the
We also help to
MHPSS
support the
surge mechanism.
MHPSS help desks.
We
what
also
provide
help to
multiple
support the
language practical
MHPSS help
support
desks
to
provide
humanitarian
multiple language
actors.
practical support
We are
to
proud to have
humanitarian
supported the
actors.
development of key
We are proud
interagency
to have
resources,
supported the development of key
Problem Management
interagency
Plus,
resources,
Self-Help Plus,
including
and
Problem
engaging
Management
adolescent
Plus,
skills for
Self-Help
emotions.
Plus,
And
we
engaging
continuously
adolescent
encourage
skills for
all of our
emotions.
partners
We
to lean into the
continuously
wealth of
encourage all of our
resources and
partners
technical
to lean
support
into the that the reference group provides in order to ensure contextualized, effective, and appropriate MHPSS responses that are in use globally, as well as responses that are in use globally, as well as to support that here in Chad. Specifically talking about the conversation that we're having on Chad, the discussion today has outlined the needs and as well of the way forward on MHPSS and as well of the way forward on MHPSS for the Eastern region. This is insightful, I think, not just for the Eastern region, the country, can and including in the LAC region throughout the country, including in the protracted and new displacement. Communities continue to face protracted and new MHPSS in Chad requires dedicated MHPSS in Chad to all crisis-affected resources and support to all crisis-affected communities. But as we heard earlier, the MHPSS are vast. And as mentioned by several times in this webinar, there's a need for us to really focus on capacitating workers for us to provide comprehensive MHPSS services to those comprehensive MHPSS services to those in need. Currently funds the Bureau for Humanitarian Assistance to respond to MHPSS needs in the LAC region, to respond to with support to survivors of gender-based violence, children in need of protection, survivors of gender-based violence, impacted by children in need of protection. Our protection portfolio aims to provide life-saving psychological portfolio aims to provide life-saving psychological support. We strive to understand the needs in Chad, and we strive to understand the needs in Chad, and we continuously are committed in finding ways to prioritize protection and PSS within our portfolio. Protection globally and here in Chad, our portfolio, and I hope that really today's conversation about the needs in Chad, and I hope that really today's conversation about the needs in Chad us to find new ways to build capacity and encourages us to find new ways to build individuals and communities with their crisis-affected individuals and communities with their MHPSS needs. So thank you very much.
Thank you so much, Anne-Marie, for this.
I would like to introduce Dr. Jamin Gelmanpour to talk about the focal points of the region. He has a lot of experience. So Dr. Ian van Engelgem, the floor is yours. Yeah, we can hear you. My screen is weird. So thank you so much, Jorge. I would like to thank you and thank everyone for their presentation. So in the past months, we have visited the Chad. First of all, we had a list. We were able to see the suffering, psychological suffering that people are living not only the refugees are living and suffering from, but also the other parties in the Chad that are impacted. And therefore, we are funding through our humanitarian funding. We are also supporting the mental health and psychosocial services since years ago. And as I was able to hear from the BHA, we doubled our budget also. And I'm not talking about the Chad only, but our global budget went from 15 million per year to 30 million per year, and even more sometimes. For the Chad and for the crisis of the refugees, we are funding several partners, and several have also activities in the mental health. So we have HI who integrated some activities in their readaptation, physical readaptation project. We have the other organization who have some specific needs. We have Alima who in their project of the primary mental health services are integrating the taking care, clinical taking care, and also other community approaches and individual approaches. We have ACF, APE, who are financing and funded that we are funding recently, and also they are offering care, primary care, and also they are providing services as much as possible for the people who are mostly in need for them. So we are talking about consultation and capacity building. Not long ago, we signed a contract with the WHO, and I'm convinced that the WHO have a lot of comparative advantages and compared to other partners that are NGOs. And in our previous work, we funded a similar activity, and we're talking here about asking the WHO to enhance the humanitarian system. And I mean by that, by the system, the organization, the structures that are working for the crisis, while integrating an enhancement for the national health system and to integrate the mental health in their national health system, as we have seen in the RDC and other countries. The national system are so weak that taking care on a higher level on the pyramid of the care would be very hard without a capacity building and without enhancing what should be there or what is there on the in the national structure. So we have a budget of 700 million euros and to include the program of the WHO, and also the WHO has other activities of funding that are dedicated to the mental health. So we have to map the needs and to support the working group, technical working group, and to do operational plan. We have the mental health kit, 12 mental health kit, and also to have the training, have a national and international consultant for 12 months, and also to have international consultants. So through all of these activities, we hope that the NGOs that we are funding or that are funded by others will receive the support from the WHO in order for them to support their activities. I thank you and have a good day, please. Thank you, Ian, for this for your experience and for your support.
To go to the questions and answers sections, please feel free to write questions. I see some of them are written already, but I would like to ask Dr. Fahmy to share with us the response he gave to the first question. So over to you, Fahmy.
Jorge, thank you so much, and inspiring to hear the intervention from everyone and from the Ministry of Health colleagues and from our colleagues from the funding agencies, from the EU, from ECHO, and from USAID, BHA. We thank you for prioritizing mental health and psychosocial support, and we kindly ask you to keep the topic on the agenda of donors, because we want to get mental health and psychosocial support needs in Chad out of the shadows and focus and make it a global priority. It's one of the major crises. It's a grade 3 as part of the Sudan response, but unfortunately across the global community did not take the attention it deserves. I look at the questions. There is a question about MHGAP and who we identified as priority targets for training. We think there is a low-hanging fruit here, despite Chad having no psychiatrist or only one paramedic with training on psychiatry. But there is an opportunity with around 20 neurologists available in the country that can be trained through task sharing, through MHGAP, HIZ. We think they are the priority. Also, the country has identified the WHO mental health kit, some prioritized medication. I shared the link in the Q&A, so please feel free to access the link here. I thank our colleagues. That was a question from Nadia, our good colleague from MSF. And I take the opportunity to thank MSF, really 3 sectors from MSF France and MSF Belgium and MSF Spain and MSF Switzerland are doing amazing work on mental health and psychosocial support in the east in the country. Alexander, thank you for your question. It's really a challenge. Yes, there is no budget available. Medication rely on procurements, donations, and the only service available in the East rely almost totally on NGOs, several NGOs, but the specialized services are mainly by MSF and IRC. I highlighted a number of questions that also relevant to the question from our good colleague on gender-based violence. The minimum service package, I think, is a key tool that you can use across sectors, not only for survivors of gender-based violence, but to avoid duplication, to use in coordination, use the gap analysis tool. I encourage also partners to use the handbook of MHPSS coordination, which can help in coordination and avoiding duplication. Thank you, Jorge, and back to you.
Merci beaucoup, Dr. Fahmy. Nous avons des réponses additionnelles de la part de notre collègue Ernest. À vous, Ernest.
Ernest, the floor is yours.
Yeah, I have just one. I see the question. Je vois la question de Doline.
Yes, I see the question from Dolun,
Doline qui a insisté pour que la santé mentale
who
ne
insisted that
se résume pas seulement aux pathologies.
the mental
Nous voulons la
social health,
rassurer pour lui dire que c'est
and we
un aspect
wanted
que nous
to
prenons très au
reassure her
sérieux.
and say that this is
Effectivement, on ne
also
se
a
limite pas seulement aux
priority, and
pathologies
we are not talking
psychiatriques,
only about
mais nous prenons en
this
compte tout ce qui est
illness.
bien-être
We take
psychosocial des
into
populations. Et
consideration
lorsque vous
all
regardez
of
les
these,
résultats de notre
and
évaluation, c'est ce sur quoi nous avons insisté le plus souvent.
I think that this is what we
Et nous
insisted
avons mis
on.
l'accent sur le bien-être
Mostly, we
psychosocial.
insisted
Et
also
il
on
est
the
aussi,
psychosocial
juste pour la
services and
rassurer, et
support.
puis revenu aussi sur un aspect
And also, I want to
qui est très
talk
important, c'est l'intégration
about a very important aspect,
du
which is
soutien
the
psychosocial dans les
integration
services qui
of the
existent déjà,
psychosocial support,
notamment dans les services d'éducation, les services de
and also
protection.
in the educational
C'est une
sector.
variable qui est prise en compte aujourd'hui et
And
c'est
this
beaucoup
is
très
taken
heureux de voir
into
cela se
consideration
réaliser.
today.
Nous bénéficions également d'un contexte
We
qui est
also
favorable parce que
benefit
le YASC, le comité
from the
permanent
support from the
interorganisation,
IASC,
produit beaucoup de documents qui permettent
and
de
we produce a lot of documents
opérationnaliser certaines
that
interventions.
allow us to rationalize
Je pense
and know
qu'avec
about
l'utilisation de
the
ces outils-là,
services
on
needed,
pourra répondre aux besoins aussi bien
and in
psychiatriques, mais
order
aussi
to be
bien aux
able to
besoins
answer
liés au
the
bien-être
needs
psychosocial. Voilà ce que je
on
peux dire pour cette
all
question.
levels.
Je
This
vois
is
aussi
my answer for the question. I also
liée à
see
l'approche
another
communautaire.
question
Effectivement,
related
Madame
to the
la responsable du programme national santé mentale
community
est revenue là-dessus dans
media,
l'une de ses interventions. Elle a insisté pour que la
and
communauté
she
soit au
insisted
centre
that the community would
des
be
interventions
and
santé mentale
should
et donc
be
apporter
in
la
the
réponse
center
à
of
travers les communautés.
the
Et je pense que
response.
c'est quelque chose auquel nous
And
allons nous
I
attaquer
think
d'ici très
that
peu de temps
this
au
is
niveau du
what we
cadre.
are going to work
Merci
on
beaucoup.
in a bit. Thank you so much. Thank you, Ernest. And I think that all the questions that were written in the message and the chat were answered. And also we have responses that were written. We went over time a little bit and we apologize from that. So I would like to thank the coordinators of the health sectors, and also we would like to thank Dr. Fahmy and Ernest and for all their findings, and also Dr. Rauda, I pronounced your name wrong and I'm sorry for that, and also for her presentation on the government needs and the reinforcement of local capacity and capacity building, and and also Anne-Marie Mackenzie and Jan Van and all the interventions, also all the people who helped us in organizing this webinar, and also interpreters who had to suffer from the speed of the interventions. And thank you all. And we respected the time allocated for us. And so I would like to tell you goodbye. Thank you so much and goodbye.
Thank you, Jorge. Thank you all colleagues. Thank you, Eric, and thank you the team. Thanks everyone. شكرا شكرا دكتورة، شكرا ليكي، وبرزنتيشن ممتازة. شكرا لحضرتك. Thank you, Jorge.